So we will just close the slides for a while.
Yeah, sure.
Hi, good morning, everyone. Welcome to 148th weekly session from CMAAO. We are live on various social platforms and on CMAAO forum. We welcome all our members from CMAAO group, all the audience on this forum. Today we are talking about prevention of severe allergies. I think this is a topic which everybody wants to know. We all are getting allergies these days in the various environment and climate conditions. So how to prevent that? We have Dr. Vijay Varar talking on this topic. He's an MBBS and MD consultant allergist, the pediatrics pulmonologist, clinical immunologist, consultant at Sai Allergy Asthma Eye Hospital, Suryadeep Hospital, Inamdar Multi-Speciality Hospital. Sir, over to you.
Thank you, Dr. Saurabh, for the very kind introduction. And very nice to meet all of you from all over the world. So happy morning, happy afternoon, happy evening, according to that. And as we know, the time has changed and the disease patterns are changing. Overall, considering like NRI patients also regularly they visit in India during the holidays, and our own patients also, we have found allergy has increased, not only the developed country, but developing countries like India also. We are seeing a lot of surge into that. And previously, 30 years back, hardly one anaphylaxis in a 6 months we used to see. But nowadays, at least 3 to 4 patients in a week we are getting with anaphylaxis with a very severe allergy. And considering these things, the treatment part too, we all are managing depending on our own circumstances, our patients' awareness about the allergy management and the affordability, the testing costs. So many things are into that. But the future will be, if we can prevent these severe allergies, whatever the tendency of the children to have such a severe presentations, as well as the potency of the allergens has increased because of pesticide use, specifically in Indian scenario, a lot of pesticides are used into the farming and artificial fertilization use. Then the cosmetics, indoor, so many floor cleaners, door cleaners, perfumes. The changing lifestyle, the diet has changed from Mediterranean to the Western type of diet. So we are also having a lot of McDonald's and so many outlets, pizzas, burgers, additives, colors into the food and all. Then sudden change into the diet patterns, like whatever the traditional diet people used to consume now, so many, even in the winter and rainy season, people are eating ice creams and cold drinks and even all packed bottles and canned foods. So these are all causing a lot of allergies. So I will try to discuss with all, and so we can have a interaction and how it can be really useful to the community. So basically, still last 34 years, I have seen a lot of misconceptions amongst the community is there. They feel whenever a child having a repeated cough, cold, or throat infection, tonsils, or most of the people talk the immunity is low. Still, I mean, many of the people, but is it that way? Absolutely not. Basically, allergy is a hypersensitivity disease. Even so many alternative pathy people, they talk to the patient that they will increase the immunity and they will reduce the allergy. It can't happen because it is a hypersensitivity disease. Basically, the sensitization goes on happening one fine day when the mast cells become hyperactivated, then the overflow of symptoms start. So it is a hypersensitivity disease. It's not a lower immunity. So even most of our colleagues also, that awareness should be brought that we should have a uniformity while explaining to the patient that it is not a lower immunity, it is a hypersensitivity. Definitely there is a Th2, Th1 imbalance. That's why some of the patients, when the Th2 inflammation increases and the Th1 cells goes down, then the secondary infections happen. So even in India, the Chest Research Foundation did a study, and so many deaths are happening because of the asthma, chronic respiratory diseases, obstructive sleep apneas leading to paralysis, blood pressure problems, secondary pneumonias, heart problems in a severe asthma patients. And this chronic exposure, which is happening day in and day out with the indoor allergens into the car pollutants, car funguses, mites, then pigeon feather droppings like in Pune, Mumbai, like urban cities. A lot of pigeon feathers are there. In the pigeon feather, there are 17 types of dust mites. Then the droppings also, aspergillus, cryptococcosis. Food allergy cases are increasing now because of, as I explained about these things. We are also seeing a lot of food allergies nowadays. So what happens here? And the concept should be that the skin dendritic cells, they go on sensitizing. And most of the children, they are around with the mother or grandparents playing with the grains and all. So these grains and all, they cause sensitization to the dendritic cell to the skin. When the Th2 memory cells increase, the intolerance starts happening. And once the child grows up, when he consumes the same foods, whatever the peanut, milk or eggs and all, he will start having a symptom of food allergy, eczema, rhinitis, sinusitis and all. So as a practitioners, our aim is that we should educate to our colleagues that symptomatically we are all managing the patients. But considering how we manage the diabetes, how we manage the blood pressure, the same way, the allergy management concept, because once allergies, always allergy till we don't manage. In between, there can be a window period, like sort of a lot of eczema children, they overcome the eczema. A lot of colleagues or GRD, 40% have a food allergy. So they may overcome the GRD, but later on, they may go into rhinosinusitis, deviated nasal septum, rhinoconjunctivitis. It's a big problem now. 95% of the rhinitis children have a hidden ocular allergy. Go on rubbing the eyes, go on rubbing the nose, go on rubbing the ears, and later on may go into obstructive sleep apnea, sinusitis, adult onset asthma and all. Specifically considering Indian scenario, it's a #1 chronic disease amongst children, third leading chronic diseases among all ages, and up to the 2023, prediction is that 30% of the population will suffer with the significant allergy. As I mentioned, significant. Why? Because recently one study was done in India, and it was found that 70% of the populations, they consume the anti-allergics as a common cold or something. But many of them are having anti-allergics regularly in their diet. So we'll see the case-wise. Like we had a significant ocular allergy child. He was from a rural area, around 65 kilometers from Pune. And in a rural area also, he had multiple sensitivities and some pollens, some dust mites. He was suggested intraocular steroids, but somebody referred to us. And when we found the sensitivity to the child, we guided them about the safe, some environmental control, some simple precautions. And then whatever the advanced therapies have been there, we had a total IG 110 for his age, it is higher. We started on omalizumab biologics, and he's within 4 to 6 months, he got such a nice regression into the inflammation, and field ulcer also started diminishing, and he was much better. So this was basically a Parthenium or English plantain sensitivity was there, and dust mite sensitivity was also very significant. So whatever he used to have a regular blanket, there were a lot of dust mites are always there into the bed and all. This was a 14 years child with a significant growth retardation, visited many pediatricians, chest physicians, pediatric pulmonologists. Most of the investigations were done, even the BAL was done for any infections and all. But when we examine, you can see the long eyelashes here, Denny Morgan folds also, and dust mite and prosopsis. This prosopsis, yellow flower pollens, they travel around 130 kilometers. And so it is a very big problem in India with the prosopsis, peltophorum, these pollens. So you can see the turbinate hypertrophy, the dark circles still over here. This was a 12 years old with a significant previous history of snoring, repeated infections, consulted many doctors. He was put upon inhalers, so many things. But when we identified allergens, we guided them about some simple precautions. Actually, he was suggested adenoidectomy also, but does not require, because nowadays it has been found very significant. If the child is having a significant sleep apneas and all, then only we should operate. Other rest of the time, we can manage with the nasal steroids, with the environmental control, the desensitization, nasal douching, and these are very good and helps the children. This was a child referred from a corporate tertiary hospital for 3 episodes of significant wheeze, required admission into the ICU also. And already they had visited the dermatologist, pediatricians, and most of them had said, like, looking at the severity, at the age of 3 months, he started having eczema. So he was counseled, the parents were counseled that it will take some time, around 8 to 10 years, 12 years. So just continue with whatever the moisturizations and all. But you can see over here the long eyelashes, depressed nasal bridge also. And once we identified you are having a milk and dust mite sensitivity, we avoided that milk in milk products also. We started desensitizing the dust mites with the sublingual immunotherapy. And within 9 months, the child showed such remarkable results. Even not only his respiratory symptoms come down, he did not require a single admission. Last 4 years, he's following with me. But within 9 months, his skin also showed a very marked improvement, because the dust mites are in crores into the, in millions into the beds. Whatever the deep cushions, the car cushions everywhere. So these simple precautions should be guided today. This was from a very good family. This child had been to us from a cornea specialist, having an early age cataract because of the repeated eye steroids. You can see the periocular eczema also. And last 6 months, his school life was affected. The children used to bully him. How you are having such a lower immunity, you are so sick child and all that way. And they used to say, bully him, like, don't go close to him. So even not only the allergies, the symptomatically, even school bullying is done into the children's. Psychologically, these children feel, why I am suffering so much, avoidance of so many foods and all. So even it has a psychosomatic changes also into the patients. So this child, if you see, he had initially gastrointestinal symptoms, then skin symptoms, then foot problems, asthma. He was on inhaler, nebulizers and all. So the allergic march was continued. In spite of symptomatically, he was better in between, but later on he had a significant, you can see how much papillae he had. So this was a child referred from a corporate hospital from the PICU. After Pariksha, this child had a peanut butter and he had a significant anaphylaxis and he was admitted into the ICU. Then after that recovery also, the hypoxia, whatever happened, the child required a lot of time for coming out of that. Now having a repeated cough, cold, antibiotics and all. That's why, and he had a significant dust mite sensitivity. Even the peanut butters and all, because of the repeated putting the hands and into that, these human danders, they fall into that, and the contamination also happens. And this was a significant oral allergy syndrome. Very few cases are that. I discussed with international bodies also about this, because peanut, he did not have a significant sensitivity. Even we did the component dissolved diagnosis also, everything, even skin test also. So dust mite contamination was into that. So if you see pharmacotherapy wise, most of these patients are repeatedly treated with the first generation, second generation antihistaminics. In our setups, a lot of first generation antihistaminics are given. It affects the sleep cycle of the children. It has a long-term cognitive behavioral disturbances. We presented a paper in Toronto, like a lot of children have the side effects of this first generation. So whenever our kids should use, they should use a safe non-blood-brain barrier crossing, non-sedative antihistaminics, because these children require a long-term management with antihistaminics. Then montelukast, whenever it is required, judicious use is recommended. Then mast cell stabilizing medication, specifically ocular allergy. As I mentioned, 95% of the children, they go on rubbing the eyes. That the rubbing will cause again the capillary breakage and dark circles, as well as it will cause a corneal irritation. The keratoconus cases, we are seeing a lot of cases with the keratoconus at the age of 14, 16 years. So the good eye drops with the mast cell stabilization, as well as oral medications, like even olopatadine or bilastine and all, in a higher dose, 4 times higher dose with the fexofenadine, also can be given in these patients to control the mast cells and inflammation and good antihistamine control. Then disease modifying therapy is the immunotherapy. And that awareness should be brought into the community, because still people don't know about allergy vaccines, desensitization or immunotherapy in India. So very few experts are into this field. It is very time consuming to explain to the patients and all, but it is rewarding to the patients to reduce the symptoms also, to reduce the medications also, and to stop the further progress of the disease, further sensitivity and further complications also. So whatever the medications we are using, besides that, most important, how in diabetes we educate to the people about simple diet control, exercise. The same way, these patients, if we identify the allergens at least, and if we can guide them what type of dust mite control should be done, what type of mold control and all, this ARI, GINA guidelines, even the gold COPD guidelines have mentioned, environmental control for that patient is very important, and so that it will help to reduce the inflammatory cycle. So as the children go on into adolescents and adults, their eczema, food allergy may overcome, but they land up into rhinitis, rhinoconjunctivitis, sinusitis, asthma, obstructive airway diseases, adult chronic respiratory diseases. So as the child grows, the food sensitization goes down. In India, we don't have that much food sensitivities as compared to the Western countries, but still definitely the cases are increasing. Then aeroallergen sensitizations also increase with the age. And as the child grows, when he has a 1 or 2 sensitizations, he goes to few to multiple, again to sensitivity and the potency increases, and then they have overflow of symptoms. The allergic march while treating these patients has to be considered, and according to the age, these different type of presentations can be there. But now it is a vice versa also. Some of the children, they start with the early multi-trigger V's or atypical V's, and then they may go into adolescent eczema, adult eczema also. Even nowadays, we are seeing some adult food allergies also significantly. So this concept of minimal persistent inflammation, which is going on, which is having a newer sensitivity pattern, should be into the patients. So 35 to 40% of allergic rhinitis may have asthma. 40 to 50% patients with allergic rhinitis also have asthma. 50% of the patients with asthma alone develop the rhinitis, and 70 to 90% of the patients with asthma also have a rhinitis. So specifically, children, out of 10 children, 9 children have always underlying allergy. Adults also, 65 to 80% of the adults, they show the significant skin sensitivity. So these are the primary allergens. The awareness is important because recently, 2 years back in the European Academy, we presented a paper around 16,800 significant chronic respiratory asthma patients. And most of the questionnaires, when we took from the patients, they had a complaint about the foods. But when the tests were done, it was actually the airborne allergens or environmental allergens. And you can see like these are the commonest one. More than 92 to 95% of the people have an environmental or airborne allergens. So why preventing these patients? The primary, secondary, and tertiary prevention should be considered. In a primary prevention, the development of an atopic disease and abnormal allergic responses in a healthy children without any evidence of abnormal allergic immune responses. So target population is the general population as well as the high-risk neonates and all. So how we can achieve that? Even there are very good like farm dust exposures, cow dung exposure, whatever the poo of that, which has a natural endotoxins and probiotics, which prevent these children. So these exposure also should be there, like a hygiene theory we call. Even nowadays, nuclear family were there. Previously, joint families used to be there. So the children used to have a natural infections. So they used to have a Th1 immunity. Now, because of the nuclear families and having all these artificial indoor allergen and pollutant exposures, they are having a more Th2 inflammation. Secondary prevention, development of the new atopic disease or the new abnormal allergic immune response in children with already established clinical symptoms or abnormal allergic immune responses. So target group are into atopic dermatitis or early sensitization to hen's egg or cow's milk. So last 4 years, I was working with the Allergy Prevention Committee of World Allergy Organization, and the specific was on only like so we can prevent the food allergies and atopic dermatitis. And now it has been recently published into the World Allergy Organization journal. Tertiary prevention is the progression of the severity and exacerbations of the already established allergic disease. So those patients which have already moderate to severe allergic disease, whatever asthma or rhinosinusitis or something, they may develop again more sensitivities. They may develop a very severe inflammation and severity of the disease may increase. How we can have it? So there are studies done. Higher intake of food-based vitamin D reduce the risk of their children getting allergic rhinitis or hay fever. Then again, some of the studies, they did not find a link with vitamin D. So there are always some postulations. We require more studies. Then LEAF study was done. and it showed that infants at a high risk for peanut allergy who regularly ate small amounts of peanut protein were less likely to develop the peanut allergies. The persistence of the oral tolerance to peanut revealed that the same at-risk infants still did not develop a peanut allergy even after they had avoided eating peanuts for 1 year. So this early introduction, specifically in the Indian scenario, that is done since ages. So that's why maybe we did not have much food allergies. Then again, feeding like 4 to 6 months old babies with the peanut powder or diluted peanut butter, and that risk of peanut allergy by 80% was found. Feeding young babies common food allergen teaches their immune system to tolerate the foods, and there are some US and European guidelines on that. And early food introduction, then avoiding the tobacco smoke, pollution, certain viruses, the RSV and all may prevent the asthma. So many of the grandparents and all, they smoke outside and they come inside, but that smoke will be always exhaled up to 2 to 3 hours. So that should be also be educated. In Indian scenarios, still tobacco burning is done to clean the teeth in the early morning. It is called misri in the local language. Then even the firewoods are still burned into the rural urban slums. Then again, breastfeeding is very important. It has multiple factors. We all know that it is very useful up to 6 months. Exclusive breastfeeding still is done in most part of India. So maybe that's why we don't have much allergies as compared to the Western country. So even there are studies that consuming milk in the first trimester, eating wheat in the second trimester, reduce the risk of atopic dermatitis, eczema. Dust mite allergy is a predictor of asthma, atopic dermatitis in children. As the child has a significant sensitivity in the early age, more chances of severe allergic disease afterwards. And those children where significant milk allergy is there, then hydrolyzed formula or amino acid formulas be used so that the severity of the sensitization can come down. Because most of the children, they overcome the milk allergy as they grow up. Then there are two sorts of barrier repair. So some of the people, research says that a good barrier to the child in an early stage. That's why nowadays, previously, the Bengal gram and milk massage used to be given, coconut oil and all. Nowadays, we don't recommend that because it may have a sensitivity from there. So now the research-based product should be used and the barrier should be improved. Then again, as I mentioned, the breastfeeding benefit, immunotherapy, definitely there are a lot of studies worldwide, more than 100 years, the immunotherapy has been practiced, and the selective patients with specific standardized allergy testing, we can help these patients to stop the severity of the disease and the progress. So the future is on probiotics and biologics. So the probiotics, the studies are happening. They are much useful in atopic dermatitis prevention and all. Still, respiratory infections and the allergic rhinitis and asthma, the trials are going on. So toll-like receptors and all, they will have an activation of the dendritic cell and Th1 response. So the Th2 inflammation goes down. So you can see this picture elaborates very nicely. So the probiotics has a different actions at a different level, or the interleukin level, at the reduction of the Th2, improvement in the IgA, improvement into the phagocytosis, interferon gamma, TNF beta factor, then reduction into the IL-4, IL-5, IL-13 level. And so that's why multiple actions are there. When there is a gut-lung, gut-brain axis. So all the gut is very important. So the more research will be required and this will be a feature. So natural infections, they prevent the severity of the allergies, hygiene therapy, as I mentioned. These risk factors in early onset persistent atopic dermatitis, then early dust mite sensitivities, multimorbid, then environment like urban and crowded without any sunlight and all, that again has that epithelial barrier defect, cutaneous inflammatory responses, atopic multimorbidities, then complementary feedings and symbiotics. These all help to understand the patients about how we can reduce the severity of the allergies. Now, allergy testing, still in Indian scenario, very few patients go for the allergy test. They don't know about that, how it is significant as like a blood sugar into the diabetes. So there are a lot of, most of the countries, they are doing that. You can see all these European Academy, World Allergy Organization, Even Indian College of Allergy, Asthma, Immunology also is recommending significantly early detection will help to reduce the newer sensitivities, and environmental control can definitely help to reduce the severity of the allergy into the future. So these are the IG-mediated diseases where the food allergy or environmental allergens, contact allergen testing helps. Misconceptions amongst the community, and a lot of ELISA method food allergy, food intolerance tests are done. Those should not be promoted because food and intolerance tests are not clinically significant. It does not correlate clinically to manage these patients. So even in an early stage, it should be, rather than in a severe asthma and all, it may not help that much. So the awareness amongst the population, amongst our colleagues, should be that, because most of the patients now we get it that when this allergy is very severe. Rather than that, when we suspect an allergy, and if we select few of the allergens, and if you do the test, it helps more than the patient going into the complications and coming to allergy specialists. So these, as I mentioned, how the standardized skin allergy tests are helpful in most of these patients. Even Indian College of Allergy, Asthma, Immunology in 2017, I was also part of that, and we had such a very well guidelines how the allergy focused medical history, because it takes a lot of time. One patient around 2 to 3 hours for his exposure, what type of where he goes, how many kilometers the child has to travel in a bus, which type of vehicles they are going, all these things, even how much air conditioning into the vehicle, because these air conditioners into the cars and all, they suck so many pollens. So the pollen filter should be there into that. So allergy diagnosis by the skin prick test or specific IG blood allergy test or component result diagnosis like multiplex assay methods. Then allergen avoidance should be educated to these patients. Not only allergen avoidance, but along with that, the indoor and outdoor pollutants also avoidance. During the winter, a lot of smog that traps all these pollutants down. So the people should be aware. When there is cloudy weather, lightning, it breaks these pollens in a very minute particles, and they rush in more into the deep into the nasal mucosa and sinuses. So there also we should guide them to use the mask. Then secondary viral infections, we call the infancy viral syndromes, like the children when they go into the nursery and pre-nurseries, they get a repeated infections, and secondary infections will trigger more inflammation. So that also should be educated to that. So what type of tests? So many tests are done, and so many advertisements are done into the newspapers by the laboratories and all. But whatever the international and as well as in Indian scenario also, we have found that the standardized skin prick allergy test in some of the patients, the specific IG blood allergy test, specifically food allergy patients, it helps. Whenever the rhinitis, rhinosinusitis, asthma, upper airway cough syndrome, tonsillitis, adenoitis and all, the skin prick test is the gold standard. You can see like even World Allergy Organization has said that most of the accurate diagnostics with the specific IG antibodies can be done with the skin prick test. EAACI position paper of 2012, 2017 also, it has mentioned that the skin prick test is still preferable considering the cost of the therapy, because hardly it is in Indian scenario 100 INR allergen. This blood allergy test, the specific immunocap, it goes around 700 rupees per allergen, 700 INR, and the other multiplex assay method also. Again, one more problem is that this multiplex assay method has some of the Indian allergens. They may not have some of the pollens and all. So again, it becomes a problem. The patient has to go for both the tests. So considering the awareness and the cost of therapy, we always prefer the skin prick test in most of the cases. When those children which have a significant food allergy, then we go for the immunocap specific IG and all. So if you see all the guidelines, even the GINA has also insisted nowadays that allergy testing with the specific IG, the standardization should be there. We can help the patients. So what is the difference between the serum IG level and skin prick is that skin prick test measures the reactivity of the mast cell bound IG, while the blood circulating IG with the serum specific IG testing is picked up. That's why some of the times it can have a false positive or false negative reaction. And it is easily available within 40 minutes, the patient get a report. Then the blood specific IgA takes some time. The cost is also high. Only thing is, some of the patients which so many skin is affected, or if they are on antihistaminics and all, then we have to wait for some time. So those cases are very small children, then we can go for the blood specific IgA. That's the only thing. And if there is a significant dermatographism or hypersensitive skin or pregnant women and all, then the skin prick test generally we avoid it. So even with the standardization, you can see how the accuracy is much better than the blood specific IgA. So positive predictive value of these patients in allergic rhinitis, it has a very good with the SPT. So it's a painless bloodless nowadays. So easy to demonstrate, hardly 1 millimeter lancet is there, more than 3 millimeter histamine, and other allergens which come positive. We have to compare with the positive histamine. And you can see the previously we used to have a 3 millimeter tip, now hardly 1 millimeter tip is used. So now recently, last 1 year, we are having this multiplex microarray assay method testing where we can identify around 120 allergens and 300 epitopes. If the peanut allergy patient is there, different type of epitopes like RIH123 proteins we can identify. And if the child which is sensitive to RIH123, it may be risky for a severe anaphylaxis and all, and they should keep the adrenaline injections with that. In Indian scenario, we don't have adrenaline ready to use EpiPen injection, but we make our usual adrenaline, 2 cc syringe, depending on the weight of the child, 10 kg, 0.1 ml, 20 kg, 0.2 ml, 30 kg, 0.3 ml. And we ask the parents to keep with a spectacle case, and it should not be exposed to the sunlight and all. Wherever possible, they can keep it in the freeze and they can carry anywhere. So it becomes cost effective. Even if the soy sensitivity is there, then the glium, pio6, and 8 storage proteins are affected with the clinical reactions up to severe anaphylaxis. Differentiate with this microarray assay method, and cross reactivity and sensitization with the lipid proteins, then cysteine proteinase storage proteins also can be identified with this. And so that is useful in some of the patients which have heat triggered exercise induced anaphylaxis or very severe food allergy suspected by the parents. We can go for that. And then the cross reactivity, like latex sensitivity has a multiple food cross reactivity. So both children, after eating some fruits, they get a symptoms. The parents blame the fruits, but actually it is a latex sensitivity. Even like a prawns or shellfish, shrimp, that topomycin, which is having a dust mite cross reactivity. That's why the body feels that this has been exposed, and the children or the adults, they show the reaction to the shrimp or shellfish. But actually it can be a cross reactivity. So we have to consider that in those cases with the insect and venoms also, we can determine with this cross reactivity and the epitopes. So we can guide the patient about that, what type of precautions are on. Suppose somebody is having a milk sensitivity with the skin prick, but here if it is a casein sensitivity more into the CRD, then the milk can be used in a baked or boiled form. So there is no need to worry much. So that way this helps. Avoidance measures has to be educated to the most of the parents or the patients so that it helps them a lot for a long-term benefit. Simple precautions like dust mite in wash bedding in the hot water, dampness and humidity should be maintained, exposure to the carpets and all the furniture should be avoided. Then pollen avoidance, as I mentioned, during the winter, use the mask during the early morning walks or something. Then into the car also pollen filters can be used. If the pets are there, possibly they should be kept not on the sofas and beds and all. So try to clean them properly. Then the vacuum cleaning, like HEPA filter vacuum cleaner should be used. Cockroaches, then avoid those type of measures for that also should be taken. The molds, then cleaning with the liquid ammonia 5% should be done. And long-term wise, repair the damage or leakage wherever it is there. So that helps the patients to reduce the medications overuse, because a lot of steroids are used in Indian scenario, a lot of first generation antihistaminics, and they have a lot of side effects. Even not only the direct, but the indirect effect amongst the drivers consuming these first generation antihistamines and causing accidents. It's a very big problem. So relative pharmacotherapy we should give to the patients, but specific allergen immunotherapy in a selected patients with a very moderate to severe allergy, which does not respond effectively with the regular antihistamines or montelukast nicotine receptor antagonists or inhaled therapies. The patient requires a very high inhaled corticosteroids and oral and parenteral corticosteroids. Then there we can guide the patients about the allergen immunotherapy. It is basically the administration of the gradually increasing quantity of the vaccine in a sublingual, oral, or subcutaneous forms, and it will have a antibody IgG1, IgG4 antibody formation into these patients, and it helps to develop a tolerance against the specific allergens. So, which cases this immunotherapy has been advised? So, all the IgG-mediated diseases, especially rhinoconjunctivitis, rhinosinusitis, nasal polyps also, if they require surgery, also it's okay. But further, they should not develop again relapse of that. So, if because of the hymenoptera, like insect hypersensitivities or anaphylaxis, and specific few patients with atopic dermatitis or significant allergic urticaria only. If it is significant, very few patients, but they will definitely require it. So always ask the detailed history of the family, parents, first degree relative, clinically examine into the patient any hidden signs of allergy, and then decide about that. And after the allergy test, always clinically correlate, is that allergen correlating according to our history and exposure. So this TH2 and TH1 imbalance should be maintained, and so that to have a long-term efficacy and control of the inflammation. So even 1998, the World Health Organization has published a paper that if you want to reduce the severity of the allergies, and not only that patient, but even some papers say to the next generation also the severity can be reduced with the proper management of the allergy. So even as I mentioned about the probiotics and biologics, now during the COVID, how the tocilizumab were used, now monoclonal antibodies were used. Now at least awareness about the interleukins has happened. But 2012 we did a study in Pune around 20 significant asthma, and we found significant TH2, IL-3, 4, 5, IL-13 were increased in these patients. So there are a lot of studies worldwide, and these target therapies like omalizumab, dupilumab, mepolizumab, deslizumab, bendalizumab, ezipilimab. We are doing trials of omalizumab, itikimab in asthma and COPD also in Pune. So it has a very good recovery to the patients. And these monoclonal antibodies directly bind at the Ig, which is getting bound to the FcR receptors, and multiple actions also like anti-IL-5 receptor also in case of dupilumab and mepolizumab, bendalizumab. Such type of will reduce the corticosteroids repeatedly, and which can reduce the anti-allergics also. And there's a misconception among the population that the allergy testing and immunotherapy is costly or it is a time consuming. But if you see the symptom wise also, only medications, the patient may overcome the eczema or asthma, but later on he goes into rhinosinusitis, adult onset asthma, chronic respiratory disease. Now definitely there is a asthma COPD overlap syndrome also. So considering all these things, he requires a repeated medications. Only in between there can be a window period or dormant period, and later on he goes to that. And where if you manage the allergies and if required desensitization immunotherapy, how we can reduce significantly long-term medications and even the newer sensitivities. Even the annual cost also in these patients, long-term wise, definitely it helps to the patients. And cost is very important in managing this patient, because later on when they have pneumonias or secondary obstructive sleep apnea or so many things, they spend a lot of money and the quality of life is very poor. So summarizing, we need a better management of allergic diseases, not only the symptomatically also, to prevent the severe allergies asthma into the adulthood, to prevent the allergic march. Then awareness among age-old outdated practices should be abandoned. Now we should use the standardized skin fit test, or if you want to have a blood specific Ig immunocap or component diagnosis, type of immunoblot techniques and all should be used, not a ELISA and RAS testing. And then avoidance measure to the community, as well as the selective, safe medications and the allergen immunotherapy as a disease-modifying therapy. So thank you. Thanks a lot.
Thank you, Dr. Vijay Warat, for that wonderful presentation. I have some questions. May I ask?
Yes, Professor, please.
I remember reading a study a long time ago. I think it was part of the Tucson study in Arizona, and where they had all these children, 6,000 kids tracked from birth to 6 years old, and they found that a big group of them wheezed early, a big group of them wheezed later, and a small group persistently wheezed throughout like 6 years. So, so it seems like the global asthma levels have doubled in the last 10 years, if I'm not mistaken. And I find in my own practice as well, sometimes I come across young children or young, teenagers with a lot of sinusitis, and have never been diagnosed. And some of them, quite interestingly, because we need a CT scan, and a nasal endoscopy is not so comfortable as well. It doesn't quite, really diagnose sinusitis. What are your thoughts on this sinusitis in children?
Yes, sir. Absolutely, I agree with you. It affects the quality of life, and even as I mentioned, rhinoconjunctivitis is a very big problem nowadays, and it is causing a lot of keratoconus. The repeated ocular steroids causing a early cataract, early glaucoma. We had a 19-year-old girl. She lost an eye because of the repeated eye steroids. 1 6.5-year-old child with an early age cataract. So the people should be aware, like, rather than using those steroids and all, they should have also the modern science diagnostics and all. They should be used in their practices.
Thank you very much.
Thank you.
Any other questions from the floor?
There's a question on the Facebook.
Hello?
Somebody is asking.
Hello. Yes, Saurabh.
Yes, Dr. Bukhari.
Yes. John, this is Dr. Kaisar Sajjad.
Oh,
Yes,
Yes,
Dr.
sir. Yes,
Dr.
sir.
Sajjad. Yes.
Hello, everybody. Dr. Vijay, it was a fantastic, excellent presentation.
Thank you.
Actually, I missed a few parts of your lecture. Basically, I am an ENT surgeon, so I enjoyed your nasal allergy, whatever you have said. My experience is, I want to share that one of the most serious, rather I can say, the complication is of the nasal allergy is the nasal polyp, the sino-nasal polyposis. So this is one of the very common complication, and the second one is the bronchial asthma. So those who are not preventing themselves from the allergen, in Pakistan, we see the lot of patients are suffering from the nasal polyposis or sinus polyposis. So this is very common, number one. Number two is my observation that regarding the treatment, when we combine the antihistamine with the montelukast, it is very helpful for the allergic rhinitis. So I don't know what is your experience, what you say about that. And lastly, my experience to be sure that I advise to the patient, you have to improve your immunity through good sleep, through good diet, and plenty of liquids, and walk or exercise something. So they all will increase your immunity. If the immunity is increased, you will treat yourself the allergies, different type of, particularly the nasals or the throat allergy. So this is I want to share with you, Dr. Vijay. Thank you very much.
Thank you, Dr. Kaisar. Actually, absolutely agree with you. Only thing is that as I mentioned, there is a hypersensitivity. So the most important is that to reduce the sensitivity, see, the inflammation controlled symptomatically sometimes maybe because of multiple factors, as like in a diabetes, the stress also aggravates. So like I would like to enlighten my 37,000 severe children with asthma allergies. During the first lockdown, not a single parent called me because the children were very happy. So did not develop any symptoms, even besides all dust mite sensitivity and all, because the parents were at home, they were used to all the food, whatever they want, and no schools, no stress. So a single stress management also can control the symptomatically the inflammation. But the long-term disease management, the sensitivity development can also be prevented with the nasal douching, nasal wash. It's a very good thing. Like traditionally in Indian scenario, nasal wash is done since thousands of years. Nowadays, we are having all these improved bottles and saline solutions also ready to use. That also should be used. Yes, absolutely. And the montelukast and all, it is a very good drug in mild to persistent, moderate, severe allergies. Definitely.
Monica, do you have anything to add?
Thank you very much.
Thank you, Dr. Rod. It's such a fantastic presentation. I can't believe how many topics and the depth and the breadth of what you had discussed today was covered. And the best thing about our field is that we take care of the patient in their environment. We take care of the patient within their family. And we see that atopic diseases are clustered within families. So not only do we take care of the child or the adult, but we take care of the entire family. So it's really nice to hear the Indian perspective. And I want to share now kind of a little bit about what the experience is from where I practice. So starting with your Th1, Th2 skewing, this is phenomenal. We see that as you live in an environment with more coliform bacteria, that you skew towards a Th1. Your immune system is busy. It's busy fighting infections. It doesn't have time to rev up the Th2, which is responsible for your atopic diseases. Your Th2 are your eosinophils, your B cells that create IgE. It's the interleukins of IL-4, IL-5, IL-13, the hormones that promote allergic eosinophilic inflammation. So we see that skewing, and that's part of the hygiene hypothesis, that living in a very sterile environment makes our immune system, so to speak, bored, and then it becomes overactive in the atopic Th2 world. Fantastic mention of that. The second thing you talked about, and you kept reviewing this, was the atopic march. So the atopic march represents 4 different atopic conditions that start with infancy and progresses through an individual's life. An individual might have all 4 stages, may have 1 or 2 stages, or you might see spattering of severity of each of these 4 diseases among different members of the family. Somebody might have eczema, somebody might have asthma. These 4 conditions in order of appearance is atopic dermatitis, which is an eczematous dermatitis that can be complicated by allergic contact dermatitis, your lotions, your perfumes, the metals. You also then develop IgE-mediated food allergy, most commonly milk, egg, then going to nuts like peanuts, tree nuts, fish and shellfish, soy, and now more recently in the United States, they've labeling laws for sesame seeds. We then talk about seasonal environmental allergies causing allergic rhinosinusitis, allergic conjunctivitis, and then developing to asthma, whether it be atopic asthma or non-atopic asthma, Th1 or Th2, or Th2 high or Th2 low asthma. So I want to talk about each of these 4 conditions in a little bit more detail. So eczematous dermatitis has faced a huge explosion of medical therapies today that we didn't have like several years ago. There's a lot of more focus now on personalized therapy, addressing these IL-3, IL-4, IL-13, the interleukins, the eosinophils. And we now have relief for kids who have moderate to severe eczema with medications beyond topical steroids with the use of Dupixent, which is an injection. Very expensive medication. Not everybody wants to do a shot, but we now have an option that wasn't there before. Okay, I'm going to swing over to food allergies now. If you have moderate to severe atopic dermatitis, you are at higher risk for food allergies. Your skin is developing, it's producing so much IgE that your immune system is revved up, sloppy. And then all of a sudden, when you have a new food introduction, you might develop IgE to that new food when you have high IgE levels and you have eczema. So the current guidelines based on the learning early about peanut allergy and with today's topic of food prevention is to safely introduce high allergenic foods early in infancy before the age of 1, whereas the prior American Association of Pediatric guidelines was to introduce foods at age 4 or older. So what do? If I have a pediatrician, I have a dermatologist that said, hey, this kid has moderate to severe eczema, skin test to peanut, we have guidelines, peanut skin test is less than 8 millimeters on the wheel, we will then recommend home introduction. If the family is not comfortable, we will do an observed food challenge. The goal being, and this is why we saw very few food allergies in our culture, is that we used to do early food introduction. We never used to follow this like eat peanuts at age 4. We were feeding peanuts to our kids when they were infants. But as the guidelines changed, as people followed the guidelines of the countries they were in, we noticed that there was an increase in food allergies. This is called the Learning About Peanut Allergy, or the LEAP study. There's been additions that have been done to that study, and we've now extrapolated that data and we've applied it to other foods, milk, egg, other stuff that we should do safe early introduction before the kid's immune system is solidified to recognize it as an IgE-mediated food allergy. Also talking about food allergies, I want to talk about 2 other things. One is that we never recommend new food introduction when a child has a viral infection. If their immune system is revved up because they have a cold, they're more likely to develop hives when they have a new food introduction that gets inappropriately attributed to the food. The patient then avoids it and then later on reintroduces it and has now a food allergy. So if a child has a few hives with food introduction during a viral illness, the viral illness is more likely the cause of the hives. The hives is not an allergic disease, it's an immune disease. And that peanut should be readdressed as quickly as possible in an observed setting. Talking about component testing, what he meant by component testing is, say you look at the peanut itself. If you pull out the peanut allergen in terms of a protein, I think of it as Lego blocks, little Lego blocks that are together. And I'm looking for the peanut component, like I'm looking for a yellow and a red and a yellow brick together. That's your ERA H1. ERA H2 is your blue, blue, and blue. If you have 3 blues and you have elevated of ERA H2, that confers a higher risk of peanut allergy. So we use component-derived analysis to be able to risk stratify peanut allergy testing. So the world is not binary. It's not black and white. We use a composite picture. We have to clinically correlate. We look at the history. We look at the food exposure. We look at, was it the 7th time they were exposed to peanut, the 1st time they were exposed to peanut? Did the symptoms happen 2 hours later, 20 minutes later, the severity of the reaction, the comorbid conditions, and what the component testing is. What we then do is, even if the skin testing is positive, I food challenge almost all those kids. I don't use a food test as a diagnosis of allergy. I just use it as a composite. And so therefore, it is very important that you have an allergist involved that uses their experience and can explain it to the patients. Because anybody who's listening to this talk, if they feel, hey, I should just go get a peanut test, I can get a blood test, I can walk over, that's not enough for a diagnosis. You need somebody who has been trained to understand what's known as a positive predictive value, the negative predictive value, the rate of false positive, rate of false negatives when it comes to food allergy testing. In the United States, we never recommend panel testing. Oh, my child has allergies, my child has eczema. Let me get a food test for 30 foods. We don't do it. Our food allergy testing is guided by history. So maybe I will skin test a child to a peanut if their sibling has a high-risk peanut allergy. But in the absence of something like that, I say this child is its own person. We are going to not assume that that child has a peanut allergy until we figure out the normal guidelines. Okay, I went a long way about that. I'm sorry.
No, absolutely. It was very informative. Thanks for that. Really.
I'll keep going. So that was diagnosis number 2. So the third diagnosis is allergies, allergic rhinitis, allergic rhinosinusitis, nasal polyposis. Huge bucket of diagnoses right there, broad spectrum. Okay. Seasonal allergies, environmental allergies, indoor, outdoor. Why do we test for allergies? We're trying to establish a pattern. If a child has a stuffy nose, a runny nose, an adult has a stuffy nose, runny nose, is it a virus? Is it allergies? If we skin test and identify inhalant allergens, we could then say, hey, like for example, in North America, I'll say ragweed counts are high. You're always having a runny nose in August. Therefore, it's likely to be a ragweed allergy. Or it could be that your child started school and they're also, being exposed to viruses. When we recommend the guidelines for allergies, and this is why steroid nose sprays went over the counter, got FDA approval, where they used to be required by prescription, is that using a consistent low dose inhaled steroid, fluticasone, mometasone, budesonide, triamcinolone, is considered to be far superior, far safer than using consistent use of antihistamines. We do not recommend Allegra or fexofenadine every day. We do not recommend loratadine every day. The only time that I recommend antihistamines every day is somebody has chronic hives. For people who have environmental allergies, antihistamines are always PRN. Inhaled steroids are done on a scheduled basis. Takes 2 weeks to work, no immediate gratification. You got to stick with it. Aim the steroid nail spray to the same side ears. Okay, so flipping over to polyps. Now, that is a different diagnosis. So polyps can be eosinophilic or it can be neutrophilic. If you have cystic fibrosis, it has a different immune basis. If you have eosinophilic nasal polyposis, which is the burden of the disease that we see in the allergy clinic, that can be associated or cannot be associated with asthma. The skin lining the inside of the sinuses and the nose and the lung is the same respiratory epithelium. If you are overproducing eosinophilic inflammation in your sinuses, similar inflammation is happening in your lungs. So when ENT is noticing that they have a lot of nasal polyp patients that have asthma, that's an immediate evaluation by an allergist who should be doing spirometry or peak flow assessments, maybe even exhaled nitric oxide to look for the degree of inflammation. Intranasal steroids, budesonide irrigation for nasal polyp prevention is very important, and so is use of inhaled steroids for asthma. We're in a new world. Direct therapy. We have depemokimab or Dupixent. We have mepolizumab, which is Nucala, and we have omalizumab or Xolair that have all been approved for nasal polyposis that are eosinophilic phenotype. There is no prevention of this disease. Some patients are more predisposed to develop recurrent nasal polyposis, and it is imperative to treat them because when they lose their sense of smell, they cannot smell smoke. It's a security issue for safety if there's a safety hazard. And it is also a quality of life issue. They cannot taste their food. To give that back, and we understand what all these symptoms mean with COVID, but we've been asking these questions even before COVID because of people who have had nasal polyposis. A word about montelukast, leukotriene receptor antagonist. Non-antihistamine does not cause sedation. Very safe. However, in March of 2020, the week before the pandemic was declared in the United States, the FDA came out with a black box warning. That black box warning said that leukotriene receptor antagonist, montelukast, can cause neuropsychiatric side effects. We had been noticing the side effect for about 10 years before that FDA warning came up. I will tell you that montelukast crosses the blood-brain barrier. If you notice that you have mood swings, that you are aggressive, that you are sad, since you started montelukast, please don't take it. Please use your steroid nose spray. So montelukast is safe. Yes, it doesn't have a lot of the other side effects, but go into it knowing that there is a potential side effect and then understand the risk benefit of taking this medication as you do for everything else. Okay, so that was a lot about nasal stuff. Last thing, asthma. Okay, asthma can have internal or external or intrinsic or extrinsic triggers. If you are around somebody who smokes, so that's secondhand smoke, or that same grandparent that was smoking outside and comes back in and has smoke residue on their clothing, that is called third-hand smoke. Smoke exposure plus pollution that you notice in next to roads and living near highways, air quality that you just talked about with the crops, these are all things that can exacerbate pre-existing asthma. But with respect to prevention and understanding disease progression, you did mention the Arizona study, and I actually don't know what that cohort found, but I do know that there was a study done by Siggers. And what that said is that if you were hospitalized with RSV bronchiolitis before the age of 3, you are more likely to develop persistent asthma at the age of 7. We then have the asthma predictive index. It's also based on a whole bunch of factors, and there are ways for you to know whether or not you have asthma. The asthma prevention is based on avoidance of viral triggers, avoidance of allergen triggers, and being able to treat with appropriate medications quickly, and to avoid the use of oral or systemic corticosteroids by maintaining with use of inhaled steroids like a combination of budesonide formoterol, where in most of the world it can be used as a rescue inhaler as well as a controller at the same time. So in one inhaler, you get to use both. Okay, allergy approach is an approach of composite factors, history. It's also testing, and it's also a discussion about the risk-benefit profile, and every patient should be engaged using a very patient-centered approach. Clinical correlation is always required, which you already mentioned, that looking at our testing results, does it actually match what the patient is saying? And it's also really important to understand that a person changes at different stages of their life. If you look at women who are pregnant or go through menopause or go through puberty, their asthma and allergy profile will change with their life, as will their profile in different environments. So I just wanted to summarize kind of like my experience in terms of my practice. And I wanted to say thank you for a phenomenal presentation. And all I did was just piggyback on what you had already said. So thank you very much.
From your end. I think it covers up very well. Anybody else has a question before we end the meeting?
Oh, yes, Dr. Sarab, I want to ask one question.
Yeah, Dr. Bhari.
Thank you very much for Dr. Vijay for your nice presentation. Most of my feedback and discussion has been covered by Dr. Monica. But I think time is too much, but only one thing that I want to ask from you. There are so many things that are covered by you both, genius teachers. What is the role of probiotics, and which type of probiotics? I think this topic has not covered by Dr. Monica, that I want to raise it. What is the role of this one, and which type of probiotics? Because the type of allergy in Indo-Pak, where the 25% of the population all over the world is living here, is different is compared to America. We are not America, not Canada, because we are in this population. What we will believe on this? Can you give some comments about probiotics? Which type of probiotics will be more protective for this allergy? Thank you so much.
Considering the Indian scenario, we have found Lactobacillus rhamnosus GG, then Bifidobacterium, then Bacillus clausii, Saccharomyces boulardii. These are the documented probiotics which have shown some benefits in different type of diseases. So that way, Lactobacillus reuteri and all for the infantile colics and all, they have been added into some milk products also nowadays. So that way. But still, we have to go a lot, because these are all studies done outside. Most of the studies, they haven't been done in Indian scenario. That's a very problem. So our gut microbiota are different. Our diet is different. Till we don't have our own studies, we can't say firmly like they really benefit, because most of the studies have been done in Western countries.
I agree. And I also think that the Asian diet is phenomenal. Like if you think about the microbiome, I mean, I grew up eating yogurt every day, every meal. right? I mean, that was, and probiotics work when you use it every day. You use it the day it works, you don't use it the next day. And the tendency in the swing to the Western diet, and it's all prepackaged food. I mean, I think when it comes to gut health, that's overall health. Our gut is our largest immune organ. And if we keep our gut happy, then you'll keep the rest of your body happy.
Yeah,
And yes, and I agree with you. But I think that there's obviously not case-controlled studies to look at one over another.
Yes, yes. Thank you. Thank you so much for this one. That is why most of the people are not suffering with allergy. If we see the prevalence of allergy all over the world, it's hardly 10 to 30% of different types. And most of the people are protective teeth to these. We are using these all things, especially in our countries. We early in the morning, our mothers, when we are a child, they gave the lassi and this yogurt and all this. I think these all things are are protective for the immunity. Thank you so much once again, inshallah.
Thank you so much. I think in the interest of time, we would like to wind up the session.
Thank you.
This was an excellent, I think, session by Dr. Vijay and followed up with Dr. Monica. I think there was a comment from Angelica saying that you should take a full session as well. So I will follow up with you for that. But thank you everyone for joining in, and stay tuned for the next session. We will report, we will inform the session again. So thank you so much for joining in. See you again.